So I think, is it on? Hello? If there's anyone who can hear me, can you hear me? Okay, so what I decided for tomorrow is that I'm going to bring a gavel, but I won't bang it too hard. I think the energy in the room reflects not only that we needed to get up and move around a little bit and finish shaking lunch off, but that we've also been really energized by the sessions that we've already heard. And I don't know how many of you have been like me, going around talking to a number of people that I'm going to keep talking to after this week is over. But there's a lot of that going around. So I'm just going to introduce Mehul Dalal and not wax on about how wise I was when I invited him to come work with me in Connecticut when I was the public health commissioner and he became the chronic disease director. Instead, I'll just sit down and let him lead this next session.
I've noticed these mics pick up even if you stand in the middle, which is a nice feature. So good afternoon. As Jewel said, my name is Mehul Dalal. I used to be the chronic disease director in Connecticut. I now serve as the Health and Human Services lead in the city of New Haven. We have a great panel because we've actually heard our topics come up in questions already in panels, so that kind of puts the pressure on us a little bit to perform. But I think we're gonna raise to the challenge here. Dr. Shelley Williams was scheduled to speak with us on the panel. In fact, she was in Atlanta, but unfortunately she got called away for a family emergency, so our thoughts are with her. I believe that her slides will be shared after the summit. So today we're going to talk about health systems during this panel. And to help us with this, we have Dr. Nicole Alexander Scott, former health officer of Rhode Island. She's going to be talking about community investments and how those can help to enhance community clinical linkages. We have Dr. Landis Coughlin from Kaiser and talking about very exciting, innovative work that Kaiser's been doing for many years in scaling up and sustaining large-scale risk factor reduction initiatives. And finally, Dr. Sean Jeffrey from the UConn School of Pharmacy will be talking about the ways, importantly, the way health systems can contribute to the exacerbation of dementia, Alzheimer's, and the complications that polypharmacy brings about. And I get to share with the panel some news that most panelists never get to hear. It's like, you can take all the time you want. Well, that's because we're down one panelist, but we do have a few extra minutes. So feel free to elaborate a little bit more than your prepared talks, because we do have some time. We've received a flood of information today. And I've heard a rumor that there might be a quiz at the end of the session. Is that right, Dr. Mullen? There's a recall quiz. So to help you with that effort, I would encourage you, if something strikes you during these talks, not just this panel, but any other panel, just write a little note down, because at the end of the day, that'll be useful when we have our wrap-up discussion. So since we have a few more minutes, I'll share a little bit about my experience as a chronic disease director and some lessons learned in terms of working with health systems. Before I was chronic disease director in Connecticut, I also worked specifically with health systems in New York City, working with various clinics, federally qualified health centers, large public health systems to help develop protocols to scale up large-scale hypertension and cardiovascular risk factor control. I worked at the New York City Health Department. And I'll just share a few tips in the way that Dr. Janet Wright did this morning, but probably not as pithy as she did. But some of the lessons I've learned in terms of engaging with health systems from the public health perspective is, number one, walk in with a plan. In Connecticut, we had the privilege of developing a coordinated chronic disease plan. And it was really helpful to walk into conversation saying, here is what we're doing from public health to improve chronic diseases in our state. And a large part of that was addressing modifiable risk factors. And then when you walk in with that plan, share with them what you think is achievable and what role the health systems can play in contributing to that achievement. And often these are population-wide metrics, which many health systems don't think in terms of all population or total population metrics. They're thinking more in terms of their specific individual or attributed population metrics. Number two, recognize that the natural state of affairs, not just in public health, but also in health systems and healthcare systems, is fragmentation. There's often competitors that are working against each other to get the most revenue, to get the most patients attributed to their services. But also that's mixed in with the various stakeholders that are working in public health and nonprofit and social service sectors, which have different, sometimes competing agendas, different funding sources, different people to answer to. So understand that walking into these relationships, that there will be a coordination and collaboration burden, and know that going in, that if you want to make this successful, you're going to have to make that commitment to overcome that coordination and collaboration burden. And then finally, when thinking about working with health systems, think about the inside levers of change and the external levers of change. So under the external levers of change are things like payment reform and incentive structures under which healthcare systems are operating. So does this mean, does your healthcare system interested in something like a bundled payment where they're paid for episodes of care, for example, for diabetes? And how does the risk factor modification align with that type of payment system? Are they moving towards a total cost of care model where they're responsible for both the total cost and the quality of care for their entire population, and understand what kind of incentives that puts the health system under? Or are they still operating primarily in a fee-for-service model? All those external factors and incentives are going to drive how your strategy is designed to engage with healthcare systems. And then there's the inside levers. And we've talked about this, not so much in terms of health systems, but some of the other talks. The inside levers are the ones that are championing your cause and championing your work. Is there someone in the healthcare system that has support of the leadership and is a real passionate advocate for fill in the blank, whether it's asthma, whether it's hypertension control, cholesterol control? They really want to do the work. They really want to engage. That's an excellent point of engagement for state and local public health departments, is to work with those internal champions that want to make it work. That's where you can find out where the small levers are for nudging. So how does it fit into the protocols of care? How is the EMR system implemented? Would a reminder system work? How does it fit into workflows? Our medical assistants or other community health workers, can they be integrated into this project that you have in improving risk factor control? So without further ado, I'm going to now turn it over to our panelists. So Nicole, I'll have you take the mic here.
Excellent way to get us started. Good afternoon, everyone. It's a pleasure to be here and to jump in talking about really understanding why it's important to recognize the necessity of, I liked your framing of being able to overcome that coordination burden that's needed. A big component of that is recognizing that any public health entity that's working with the health system, both of you have to coordinate for the mutual purpose of engaging and supporting and serving the communities that you're in and there to help improve and recognize what challenges they are undergoing. So it adds an additional dynamic to that coordination burden, with the focus on those who we're looking to serve at the community level, mostly because they have the strength and capacity to do what's needed in the communities that they are living in, but have been existing in systems that had been designed to ensure that they weren't successful. And so there's an opportunity in coming together with a health system to ensure that you're united in addressing what's needed for those communities. So I want to start with delving in on that why it's necessary to have the communities at the forefront of what we're looking to achieve. We oftentimes forget because of the focus on health systems and public health, why we are there. And hopefully you can leave with that understanding of, attention to what we're looking to achieve. And then also delve in for a few minutes on the two approaches to investing at the community level. So our current situation is such that there are places throughout the US that have been disinvested in repeatedly and over time due to unfair policies that deny opportunities and shrink resources, particularly in communities of color. That is why there is no surprise when you can go to any particular area or city around the country. And when you see a similar demographic, you also see the same outcomes of those disinvestment approaches. As a result, what we see is there are lives that are cut shorter in those places, significantly so. Those places that lack basic services and critical infrastructure. It didn't just happen that we have those disparities. It's also a matter of recognizing that there were systems and institutions and policies and structures that were set up to lead to those differences and are still in place to continue those differences. We have to be intentional in our coordination and in our approach, particularly for our older population, to make sure that we understand who we're doing it for and what they are dealing with and why. We know that those communities where the lives are cut shorter are suffering from those lack of basic services and critical infrastructure compared to those other communities that do have what they need to live longer. Quality jobs, quality schools, safe homes, actual clean and taken care of parks, actual safety in your community, access to quality medical care for the number of reasons that are needed. And so there needs to be, in our approach to dementia, in our approach to so many of those long-term impacts of society, there needs to be an understanding of how we can incorporate the balance that we need where lives are cut shorter and recognize what people living in those communities are facing. So what's the solution to that? Community level investments, ensuring that our focus on building capacity and meeting the strengths of communities that already exist is centered around the community leading that process of investment that occurs. It's not saying you're a community that's been disinvested in, here are your problems, and these are the only ways that you need to fix them. But it is saying, how can we take the resources that should belong to all communities, but help ensure that it is investing at the level that we know is needed and that the community can help direct. And so that shift is with the understanding that 80% of what matters for health actually happens outside of the examination room. We do understand that. It's in our homes, our schools, our jobs, and the broader parts of our community. I can say that confidently as a physician as well, an adult and pediatric infectious disease physician. So when we see that clinical care actually makes up 10% of what determines our health outcomes, we have a motivator for how to shift investments so that there is more of a balance. Instead of 60, 75% of resources going to just the clinical care piece, it's understanding that there are social and economic factors and physical and social environments and the health behaviors that are a result of those factors that we can also focus on. So in our two approaches to addressing that shift in investment to the community level, we can take the clinical to community invest linkage perspective, and that's one I'm going to expound on a little bit more today. And we can also think about direct investments in community, which I'm also very passionate about and want to lift up because that helps us in tackling the policies and systems and structures that we know over the long term have led to why we have such disparities across communities. So our theory of change for achieving community revitalization, which is going to be critical if we want to change the dementia risk factors for entire populations. We have to look broadly at the communities that people are existing in. It is looking at community development, building on the strengths that exist in those communities and helping to enhance that, and combining that with sustained investment, braiding funding, strategies for ensuring that there is long-term investment rather than just sprinkles of funding that can exist but not lead to the transformation that we know is needed. Bringing those two together can result in the transformative impact long-term that we know is needed. So if we delve in a little bit more on our clinical to community linkage approach, there are multiple ways we can continue to strengthen that. Many people talk about our global waiver that's available through CMMS as an option, Medicaid, Medicare. There are also opportunities in terms of other forms of reimbursement that exists. All of those should be used to further support the opportunity we have with community health workers. That is another route that is viable and necessary to continue to strengthen our ability to build capacity and support resources that are needed at the community level. It's one of the many ways we can shift investments and really place our focus on the community where it matters and where people who are living through the conditions that they are living in understand most what is needed to help make the change and make the improvements so that they can have better outcomes, whether it be dementia or other chronic diseases or just their environmental policies and systems and structures that are in place. So continuing to recognize, particularly in our coordination with health systems, the value of community health workers together is an important step, because then that allows us to think about ways to ensure that they are compensated and reimbursed and paid for effectively, knowing that these are frontline public health workers who are trusted members of their communities and can be a nationally recognized model for improving the community's health. They're hired for their understanding of the populations they serve and can help enrich what is needed and what exists already in those communities. I like to say that the embracing of that entire profession of community health workers can be as broad as we want it to be and need it to be, to uplift those groups of individuals together as a profession. You can have community senior care navigators. You can have chronic disease case managers, which we know we have. We can have public housing resident coordinators, case managers, peer recovery coaches. Across the board, you can have individuals who are able to build on and strengthen what exists at the community level. A helpful distinction I've appreciated lifting up so that we're not stepping on toes when we're talking about and advocating for community health workers to be able to contribute to the health system's work and what's happening at the community level. a helpful distinction is recognizing that you can have licensed health professionals who are community based. They may or may not have an additional certification. They may travel out of their centralized healthcare setting and go into the community. And in general, not limited to, but in general, can focus on clinical education tailored to the recipient. That can be complemented by having a community health worker type of role where there isn't necessarily a definitive health professional license that's in place. There can be a community health worker certification. There doesn't have to be, but ways to continue to elevate the importance of that work exists and can continue to be promoted, and have it be someone who also travels out to the community to have the positive impact that they can have in someone's home, in their neighborhood, in their surrounding area. And someone that focuses more so, also not limited to, but more so on helping to navigate the social services that are needed, or what the challenges are in the community level and area. And there are different examples of this for community-based licensed health professionals. You can have pharmacists, nurses, social workers, nutritionists, dietitians, EMT, certified tobacco treatment specialists who may be one of those licensed healthcare professionals. And then you can have a community health worker who has the tremendous lived experience and also helps the individuals that they support, the families that they support, navigate what's needed at the community level. And you can imagine how critical this would be for the dementia risk factors that we are continuing to highlight and spotlight, and ways to get at having an impact at the community level in a way that ensures equity across the board for what people can handle and deal with. If we look at the research that exists, there are a number of ways that community health workers can add value. If we focus just on the clinical setting, being able to build into the portfolio of the roles that we want health systems to value and hire and pay for includes, but isn't limited to, the complementary nature of community health workers in being part of a medical team that can be trained to also value the importance of our community health workers, whether it be the case manager who can help provide transportation, or someone who can go into the home and understand, is there electricity, or is there enough safety in the home, or do the children have what they need, all of which can contribute to addressing the risk factors that we know are critical. Community health workers don't have to be this esoteric involvement or role, but can and should actually engage in the evidence-based activities and helping to implement them effectively. We know with community-based participatory research, or just everyday involvement in healthcare, it's all contingent on what the individuals are experiencing in their living conditions and in their surroundings, and how they're able to navigate that, where a community health worker can provide significant value. They can also provide opportunities for collaborations within and across clinics, and really help integrate what's needed for the families and individuals to receive the comprehensive care that we know is so needed. There's opportunity to better co-locate community health workers with our health systems, and be intentional about the value and necessity in doing that, whether it's contributing to the transportation or just being present to support the social services, or to travel with the patient back into their homes and really help understand what's needed and effectively communicate, translate for the family and the medical team what the real challenges are. So instead of a patient becoming hard to reach, or someone who is, resistant to care or something like that, we can overcome those barriers and really help ensure that we're taking this comprehensive prevention approach that is being discussed today and is such a critical model. This diagram essentially shows what the outcomes can be for how a community health worker can be engaged directly in a health system and support the work. If we just focus on diabetes as one of the dementia risk factors, all of the areas where a community health worker can be involved, and this shows demonstration of reporting their input and assistance in helping to really make a difference. I wanted to also quickly show, because there is science and evidence to reinforce the value of having community health workers engaged in what's needed. This focuses on asthma, but is extrapolated to all of the dementia risk factors that we know are important, as well as the social, economic, and environmental conditions that we know are critical. When you engage a community health worker in the home with the family to complement a community-based licensed health professional, you're able to see significant improvements in outcomes and in costs. And from a health systems perspective, this kind of data and information is definitely critical. I want to finish with touching briefly on the other way to also continue to strengthen investments at the community level that can be important for not only dementia risk reduction involving policies and systems change, but across the board in terms of that long-term transformative impact that we're looking for with community involvements. With a special shout out to my colleagues here who are from Rhode Island, I certainly want to lift up the example, one of many throughout the country that are in place for community-led models that help ensure that residents, businesses, all sectors at the local neighborhood level can come together, have their voice lifted up to inform the direction that their community and their area needs to go in based on the data and their own lived experiences. You can apply public health principles, put them into action, bring a collaborative together, have data to help inform where they need to go to drive collective action, set goals that are unified based on that data as an action plan with measurable objectives that we want to move towards together, and with unified braided funding injected into that infrastructure and support, you can not only drive towards outcomes, but you can measure them and evaluate the benefit and importance of that, and lead to that transformative impact. You can have community health workers be able to support at that community level and make that connection that I spoke of earlier between our public health and health systems engagement, so that when we have community-led, place-based strategies, that can be the basis for policies and systems change that we know is needed. We can engage community health workers to address the root causes of health inequities at the community level, and ultimately improve living conditions within those communities without causing community displacement, because you're bringing in resources and have to move them out in order to bring another community in. But you want them to be able to stay and have reinforcement of the support that they deserve and that they need. So I'm going to finish with the highlighting the fact that health systems and providers are well positioned to implement community-based solutions, having their eyes on the proper prize of why they're working together, and ultimately address the dementia risk factors and the other long-term outcomes that we know are so necessary. And this is a great opportunity. Give credit to the co-chairs who have brought everyone here together to educate and influence the understanding that we all have of how community and clinical linkages, as well as direct community investment, can strengthen addressing risk factors for dementia in a comprehensive way. So I love the discussion and being able to get at it from every angle. And thank you for the opportunity to contribute.
Oh, yeah. Go ahead. So that was great. One of the things that struck me is how you conceived of community health workers as a much broader effort involving many other members that are doing the work day to day. So I think that's very important to keep in mind as we think about these issues. So next, I'll turn it over to Landis.
Hello there. Hopefully everybody's still awake. That was fantastic. Thank you very much. Thanks so much for including me in this amazing conference. I feel like I'm coming at this conference from a different angle, and my eyes have been opened by the really wonderful presentations today. I'm a primary care doctor. I work at Kaiser Permanente in Santa Clara, California, and I'm also our Northern California clinical lead for hypertension. So what I look forward to doing today is telling you a little bit about our story for population health and how we've really, over the past 20 years, put together a great population health approach to hypertension. And hopefully there are some pearls in this that can apply in your projects as well. So thankfully, there are some really eloquent speakers already today who have made the case that hypertension is a big risk factor for dementia. So I don't feel I need to do that one again. But I do want to share with you a little bit about who's Kaiser Permanente, what's our story, and then really drill into the details of what are the ingredients in our approach. So you guys have seen slides like this so far today, and the ones we've seen are better. But I think we can all agree that hypertension is a really big risk factor and a very prevalent risk factor that we can modify and hopefully lower the risk of dementia. So who's Kaiser Permanente? We are a managed care organization that really has at least three components: a health plan, a hospital group, and Permanente medical groups or doctor groups. We have a predominantly or a large West Coast presence, but we have a presence around the country. And in Northern California, where I'm coming from, we take care of more than 4.5 million members. In 2000, we started a big population care approach to managing cardiovascular risk factors. We really focused on diabetes and hypertension. And over 15 years, we really honed some key aspects to this program. And we were very successful with the implementation of this program. As you can see, over the 15 years of really focused work on this, we were able to increase the level of hypertension control in our older or Medicare population from about 55% to 95%. And in our slightly younger commercial population from about 55% to about 85%. And we're going to go through and this was all in a time when the national benchmarks didn't really move all that much. So there are some key learnings from this. And why does it matter? Well, because of this really intensive focus on reducing the cardiovascular risk factors, because of good blood pressure control, because of good diabetic control, because of attention to adherence to statin medications, we have cut in half a Kaiser member's risk of dying from heart disease and stroke. So there is a big so what to this. So what are the key ingredients to this program? And I'll go through each one in more detail in a moment, but we need to be able to identify who our patients are. Who are our members with hypertension? We need to make that easy. We have developed a very streamlined, evidence-based blood pressure medication algorithm that's flexible and is not, thought police. But I'll explain the benefits of having a very streamlined protocol. We we use metrics early and often and frequently, and I'll explain the benefits of using metrics and how they reinforce engagement. Team effort is really the key message to how we can continue to keep engagement and how we can make this work and how we can extend the small resource that is a doctor's time. And then how do we reinforce and keep up our quality improvement culture? So in more detail, we need to know who are our hypertension patients. And so we have developed a registry. A patient comes into our registry if they've had 2 diagnoses of hypertension in the past 24 months. And a big development there are a couple good things that have come out of COVID. One of them is that we can use home blood pressures, and if a blood pressure is documented as part of a telehealth encounter, we can capture them in our registry as well. We have made our hypertension registry with a broader net than the HEDIS definition of who hypertension patients are, because we think it's the right thing to do. We want to identify all these patients at risk. And because we now have a database, we know who our hypertension patients are, we're able to use that information to create tech tools that allow us to identify these patients at the point of care. And that, I think, is the key point. We're able to know when these patients are due to get a blood pressure checked. We don't have a flag that comes up every time saying this patient has hypertension. But if it's a patient who has hypertension whose last blood pressure was too high, or it's been a year since they've had their blood pressure checked, there's a flag at the point of care, and not just in primary care. This is across the whole enterprise. We have this evidence-based, streamlined blood pressure medication algorithm. The benefits of this algorithm is that it reduces clinical inertia. I expect folks in the room know that clinical inertia is a big deal. We have this protocol at everyone's fingertips. If you can't remember, what am I supposed to start first, or what should I think about? Boom, you could bring it up at the point of care. It also allows for really good teamwork, because if I'm seeing my colleague's patient and they started him on Prinzide, my colleague can guess what I'm going to do next if I need to titrate the medication. Also, I will often share blood pressure management with clinical pharmacists. They also can start and titrate medications. And of course, this has to be flexible, allowing for clinical needs of different patients. And absolutely, doctors can choose a different path if it makes more sense for taking care of the blood pressure. But having some framework and some reference really streamlines things. Another key aspect of this blood pressure protocol is that these are generic medicines, and they're medicines where the dose can be scaled often several times without a patient having to go buy more medicine or go back to the pharmacy. So it's really got patient convenience and cost effectiveness built in as well. And we are reassessing this protocol 4 times a year. We're actually due to have a conversation to reassess it again. Every time there's an important study that comes out, every time we want to think about, are these the right medicines? Internal metrics are a key strategy. We are following process metrics as well as performance metrics. And I would argue that maybe the process metrics are the most important. For example, we are following what percent of patients who have hypertension who interacted with our system had a blood pressure recorded. Doesn't matter if they were in podiatry or checking in for ophthalmology. We are monitoring that once a week. We are monitoring what percent of patients with hypertension whose last blood pressure was high had a follow-up blood pressure recorded within 30 days. So these process metrics can help us think about whether workflows are effective and can keep people engaged. We all like to see some benefit to the work we're doing. And of course, we do follow performance metrics as well. The metrics, we publish the metrics internally, and facilities can see other facilities' metrics. This is very transparent. And the culture around metrics is very, I want to say there isn't that much drama involved. It's not punitive to talk about metrics. It's very proactive, and we use them. I'm on the regional clinical lead, so I'm looking at the metrics of, gosh, who's doing really great? Why is this facility, why did it drop off last month? We're always looking for, what are they doing? Is there a best practice we should share? Or, ooh, let's talk to them. What are they doing differently that maybe they need a little help or some resources? We need to understand what's going on. And by being very proactive about going through the metrics, we can recognize problems quickly, and sometimes we can share best practices very quickly as well. I think I covered all those things. The team effort, and when I say team effort, it sounds like one thing. No, there are so many teams that are involved in maintaining this program. There is a team effort among doctors and among clinicians and staff, where there absolutely is the expectation, because we've got these point of care tools, everyone has the banner that says this patient needs a blood pressure. And we have metrics that show whether folks are using them. So there's absolutely an expectation that if a patient's checking in, I don't mean to pick on podiatry, I'll pick on, if a patient is checking in orthopedics, I would expect that they may not always check the blood pressure with a blood pressure cuff, but they will ask the patient, do you have a blood pressure from home? Do you have a recent blood pressure? Oh, your last blood pressure was high. Let me book you a follow-up blood pressure appointment. So blood pressure needs to be brought up at the point of care at all contact. And that is a team among providers. There also is a team that focuses, we absolutely require teams to focus on education, patient-facing education. It's not realistic to expect that in a 15-minute visit with a PCP, when the patient comes in with 6 other things, that a doctor is going to do all of the DASH diet, lifestyle, motivational interviewing that is required. And frankly, patients need this information when they're ready to lean in as well. So we have a team of health educators and nutritionists that can support all of these that are motivational interview trained, that can support patients and meet them where they are. We as primary care doctors can refer patients, but also patients don't need a referral. They can call directly, and there are online classes, there are in-person classes, there are websites with information. Our medical assistants are major team members here. One of the big innovations that yielded that really big improvement in the early 2000s is that medical assistants have their own 10-minute blood pressure checks. The patient is not billed for this interaction. Patients aren't seeing a doctor, so they don't get as much white coat hypertension. And we can offer these appointments at more convenient times for patients. Often we can have evening and weekend, the actual in-person blood pressure checks. And now we also have phone check-ins about blood pressure. I think it's really important for patients to have a scheduled date and time when somebody is going to hold them accountable about their blood pressure. But it can be from home. And that works really well for folks that have transportation problems, and where it's just not convenient. In fact, I have plenty of appointments with patients when they're at work. Right. Clinical pharmacists are also a key part of this team. As I mentioned, I will share patients with. As a primary care doctor, I have 1 or 2 clinical pharmacists I work with mostly, but so we're sort of clustered with who we work with so that we can have a warm handoff. But sometimes my clinical pharmacist will start medicines, sometimes she'll titrate them, sometimes I will. But that is an absolute great use of sort of extending the physician time. And I know what she's going to do because we have a streamlined protocol. And then there really is this cultural expectation that everybody who touches this patient is mentioning blood pressure in some way. And finally, the culture of quality improvement is really key. It's hard to sustain, to be honest. It requires a lot of active engagement to sustain it, but we must keep up this culture. Things that help sustain the culture are the tech tools that are at the point of care, the reference to metrics and the use of the metrics to have, as somebody brilliantly said earlier, it's not the metrics, it's the conversation about the metrics, but they start the conversation. What's going on? We need to check in about this. And we have meetings at every facility. We have an operational champion for this work, and we have regional check-ins with them as a peer group about twice a quarter, where we review metrics, we talk about best practices, and again, we have sort of a culture of safety where you can talk about what's not working as well, so that we can problem solve and share ideas of workflows. And a lot of good workflows and innovative thinking comes from the front lines. Not surprising to you folks, I'm sure. Yeah, so it does take active engagement, but continuing this culture of quality improvement and safety in the discussion around metrics is really a key driver here too. Just 2 other things. Our streamlined medication protocol is actually in the Million Hearts program as a reference. And I just checked last night, so that is not an out-of-date comment. And I just wanted to finally say that, in the past couple of years, disparities, closing the gap has been a major focus for us in the hypertension work as well. And we know, and it'll come as a shock to no one, that young Black individuals with hypertension suffer a disproportionate poor outcome. So to that end, we've really beefed up our resources, focusing on this population as well. We've got some cooking classes and demonstrations. We've got a lot of increased effort with the DASH diet and nutrition. There are some videos and websites and classes that are specifically focusing on this group. And in May 2022, one of my colleagues published a trial called the Shake, Rattle, and Roll trial, where they recruited, I think, 1,600 Black individuals with hypertension. And it was a randomized trial where they focused on the question, does increased intensification of blood pressure medications or increased intensification of lifestyle reinforcement or usual care work the best? This is a quiz for the audience. Which one worked the best? Lifestyle. Yeah, you guys are a smart group. But it reinforces your role in all this as well. Of course, my patients don't want to take medications. Sometimes you just take medicines and do the lifestyle stuff. But if we can have many frequent touches with patients who feel empowered and knowledgeable of what kind of changes they can make and sustain for their own lives, that's really the sweet spot of where we want to go here. Thanks so much.
That was great, and it's just an example of how working with health systems, or how health systems can contribute. This is a real grand slam for public health. You know, a 48% reduction in cardiovascular mortality. That is just spectacular. And I think where you really worked a miracle land is having orthopedists talk about blood pressure. That's amazing. All right, so I'll turn it over to Sean for the next talk.
All right, thank you all. And now for something completely different. I stand between you and 5 o'clock. I'm glad you all applauded when you said we had extra time, but I'll try not to use too much of it. I do have the good fortune of being the last speaker of the day and having been taking notes copiously on what everybody else has been saying. So I'm going to try to the best of my ability to tick and tie back some of the things in my presentation to what others have mentioned earlier. So as Mehul had mentioned, I'm a pharmacist. I'm a professor at the University of Connecticut. I'm also director of pharmacy for Hartford Healthcare's Integrated Care Partners, where I work within our integrated delivery system to help provide pharmacy support for the quality and the cost issues around Medicare beneficiaries. So thinking about pharmacy quality measures for any of our Medicare recipients, a lot of that deals with medication adherence. So what I want to bring back to all of you now is, since we're talking about risk reduction, and I haven't heard a lot about medications, let's frame this next part of the discussion around medications as a potential risk for our dementia patients. And ask yourselves, how can we be better stewards of these medications in patients that are potentially very frail and at risk of making mistakes with their medications and potentially getting things confused or forgetting to take something. So that's the framework by which I approach this summit. And I'll lead into it a little bit further by saying, you don't know what you don't know. You can't manage what you don't know. Meds don't work in people who don't take them. Largely to Landis's challenge around getting blood pressure under control, a lot of that work is often the barrier of medication non-adherence. Somebody's not taking their medications for whatever reason. But do you know if they're taking their medications? Do you know what medications they're taking? One of the things that we were talking about earlier that struck me as I was listening to all of the risk factors that were being presented is that we don't highlight medications as a potential risk factor here. Yet we routinely screen for challenges in being able to manage medications. Think about your instrumental activities of daily living. Medication management is one of the things that you're screening for. And I know that med management in individuals who are facing mild cognitive decline, who are beginning their journey with Alzheimer's, that's like the canary in the coal mine. It takes a high level of processing to be able to manage those medications, right? I know what it looks like. It looks like this. This is the dementia patient that I went out to visit in his house. And we saw him in clinic, and he was struggling with being able to tell us what he was taking. So when I got to his house, and he lives in a trailer, and it's important that I bring that, it was a trailer because he was also a hoarder, and the trailer was collapsing under the weight of all the stuff that was in the trailer. Does anybody know what this is? The white container here. It's a lid. This is a Cool Whip lid, to be specific. Do you know what this lid is? The one above it. It's a smaller Cool Whip lid. This, however, is the reference lid to how he sets his medications out every day. This is IADLs at work. The morning meds are on this side. His noon meds are about at 12 o'clock, and his afternoon meds are on this side. Okay? Now, some of you are fast forwarding in this conversation thinking, there's some problems with this. How do you take your reference lid to your doctor's visit to say, here's what I'm taking and how I'm taking it, right? So these are the challenges that I think we have to routinely screen for in our patients to root out, because this is a nightmare waiting to happen. Very easy to get confused. What happens if you tip over your lid? What happens if you lose your reference lid? Now, just to take this a little bit further and see how sharp you are in the afternoon, who knows what this is? That's the pill splitter. Yes. And that is? Yes. Okay. This is a sharp audience. So what do we need then to try to prevent this from happening? In my work in health systems, and I've been in a variety of them over my career, I've distilled it down to basically three things. We need to increase the accountability that we have as the providers for understanding what our patients are taking. We need to try to reduce the complexity of the medication regimens we're asking people to take. And we should strive for simplicity across the system. Okay? And what that often leads to is this challenge of med reconciliation. Okay? Where we have, on the one hand, when the clinician sits down and wants to try to go through with the patient's medications, the first thing they want to do is hit the escape button. Because it's very, very complicated. And to Dr. Esther Brooks' comments earlier, this is the definition of high complexity with low compatibility. Okay? So we have, we want to hit the escape button. Many times we just like to hit the delete button to get rid of medications, and that's a whole Pandora's box in and of itself. We're going to talk a little bit about the challenges of deleting things. And then what you're ultimately left with is the fact that you're making decisions off of a fictional or a non-fictional list. So what are those decisions going to mean if it's a fictional list of meds? So to one of our earlier comments that was made, and I'm sorry, it looks like timings are on here, so my slides are advancing for me. It's going to keep us on time, right? So the challenge here is we need to make sure that patients actually have access to their meds, that they have access to the list of their meds, and that we all know as the providers involved in their care what those meds are. And right now that's elusive. That's the challenge that I want to leave for all of you, very smart people in this room, to help us solve. How do we make med reconciliation consistent? How do we improve it across the entire care continuum? Because this is kind of what it looks like right now. We have a med list, which is largely fictional because it's being derived from different data points. Some of it comes from an EHR, from when somebody enters the orders in. Some of it may come from prescription data that's being dispensed by the pharmacies, which is captured in claims data that a payer receives, that then may get fed back into an EHR system that then generates part of the med list. And ultimately, we don't always know what's going into the mouth of the individual. So we need to be focusing a holistic approach as to how do we solve for all this disparate data. And we get to the point where we create something that looks more like a best possible medication history. And this is a term that's used in the literature to describe the process by which we obtain the information, the medication information, how we reconcile that information, and how we make it available at every point in care. This best prescribed medication history is not something that is static. It's a dynamic process. It has to be able to change, and it has to have inputs from both the provider side, but also ultimately the patient should be able to help reconcile what medications they're on. If somebody with dementia decides that they don't want to be on their medications anymore, you need to know that. We need to be able to see that that's been stopped, who stopped it, and when, and ideally why. Now, I've talked briefly about what the challenges are with med reconciliation, The reason that this becomes so important is because of the medications that patients are often exposed to. And there are some challenging medications for older adults. Specifically, there's a criteria that exists that's just been updated as of like last week called the Beers criteria. Can I see a show of hands if people have heard of this before? Those are the folks that raise their hands that are familiar with the lagers, ports, and ales version of the Beers criteria. I'll tell you about the other portion. So the American Geriatric Society has put together a list of medications that basically it's the thou shalt not use these in older adults. Great information. We'd like to take this information and make it so that it's available at the point of prescribing, so we prevent people from getting on things that we know, if you have cognitive impairment, will worsen your cognitive impairment. Medications that have high anticholinergic burden, which cause you to be blind as a bat, mad as a hatter, all those strange things that they can cause you to be. We want to avoid those medications from being used. So you have to be able to know what patients are taking in order to manage what they're taking, in order to also prevent them from receiving these potentially harmful medications. The other component to this is what happens if they're on a medication that we know causes cognitive impairment. And the prototype of this would be benzodiazepines, Valiums of the world. We don't want older adults taking Valium. It has a whole multitude of bad things that come with it, but namely it can cause cognitive impairment. So one of the things that is a strategy that we can now employ once we've done a good job of reconciling medications is to use tools that are out there, evidence-based tools, to help in de-prescribing. So to help prune that list of the medications that patients should no longer be on. And I would direct you to our fellow colleagues up north in Canada who have done a tremendous job at creating patient-led initiatives that have been shown to allow individuals to recognize when there may be an issue with a medication using a process of cognitive dissonance, to then be able to say, hey, I've been taking this medication, maybe I shouldn't be taking this medication, and oh, by the way, here's a step-by-step approach to how I can remove that medication, and I can do it at my own schedule. And they did this successfully with benzodiazepines, which many of us would think, that's crazy to think that you could get people to self-taper off their benzos, but it can work. And you do that on a population level now, and now we've had a way of reducing risk substantially, because there's a whole host of these meds that are currently being used that do cause cognitive impairment. Some of them do cause structural changes in your brain that may portend to dementia. So we want to try to make sure that patients aren't getting access to them. And if they are, give them the off-road. Help them with the directions on how to remove the medication safely. The last thing I'd like to touch on is a comment that was made by Dr. I think it might have been, let's see here in my notes, who was talking about caregiving burden? Dr. Stevens? Dr. Stevens. So medication management is a huge burden for patients at home. It's something that scares them and creates a lot of anxiety, especially when you're struggling to get somebody to take their medications properly. This is an individual who I also had the pleasure of seeing, and the reason I was asked to go out to see this patient, and he had just been discharged from the hospital with a COPD exacerbation. He has dementia, and they got home, and he was supposed to be taking an antibiotic, and they couldn't find the antibiotic. No surprise why they couldn't find it. It got mixed in with all the other prescriptions in their house, and the wife got very concerned and overwhelmed. And we had to go out and try to help straighten out all of the medications that they didn't need that were confusing the individual. So we have an opportunity again to help reduce the burden, to help with caregivers, help them to not feel overwhelmed by this very daunting process of trying to manage medications. And when it's done well, we're saving dollars, we're potentially reducing risk. We're now at the Q&A, so I guess you'd let me off the stage. I'm still on time, but there's an opportunity here to really, I think, help extend. Oh, now we're back to, I didn't do that, but we're back to getting rid of all the medications that they don't need. And for any of you who have ever done a home visit, any home visit folks out there, it is amazing how many meds people will squirrel away for a rainy day. And we want to stop those rainy day meds from making it back into the system. So my final point to you, and I made this a little bit earlier, I said I'd come back to it. How do we get rid of things and have them from stopping to pop back up? So my final plea to you who work within health systems or working with your pharmacies, working with your provider groups, we want to increase the use of a standard called Cancel RX. Now I'm going to get slightly wonky for you. When a prescription is sent from an EMR to a pharmacy, that's e-prescribing. When you want to cancel a prescription in an electronic medical record, it just cancels in the record. It doesn't tell the pharmacist to not dispense that medication. So if we want to prevent accidental refills, we need to increase the use of Cancel RX, which is the standard by which the EMR talks to the pharmacy and removes that from the pharmacy. The more you bring that to your communities and you make people aware that this is out there, the greater the uptake is going to be. It takes some programming, it takes some work on the IT people's part, but in Connecticut, we've been able to successfully show we increased our Cancel RX transmissions like 1,000-fold just by doing the work of letting people know that this exists and here's the benefit to the patient and to the system at the back end. So I think I've covered all of my talking notes. One last thing, some competitive statistics for Kelly. Are you still here? All right. So Kelly, 90% of people live within 10 miles of a Walmart, but 90% of Americans live within 5 miles of a community pharmacy. And to Dr. Lennon, if you want to know who to partner with and what organizations, I would suggest your community pharmacies. The average Medicare beneficiary goes to a community pharmacy 35 times a year. So that's who attends and how often. And the pharmacies have space and would love to have that conversation around what matters most to those patients. So don't leave out your community pharmacists. Thank you.
Thank you so much, Sean. What a great talk. And another round of applause to the panelists who kept this crowd engaged. I think what really struck me, Sean, about your presentation is how that actually is really complementary to what Landis was talking about. You want to stick to an evidence-based, strict protocol, scale-up hypertension control. Well, what's everything getting in the way? Well, polypharmacy is getting in the way. Unnecessary meds are getting in the way. So I think it's very complementary. I don't see anyone at the mics yet, so I am going to kick off with a question. We talked a lot about the internal practices, workflows, best practices we could change. Maybe I'll direct this to Sean because we talked about this before our session. What are some of the barriers and challenges that you might be facing in terms of payers, or what payers can be doing better to incentivize some of these best practices?
So I'll sit back just a little bit here. It seems very loud to me. In my role, I have an opportunity to work with many of our different payers, and their concern is rightfully around cost. They have concerns around quality. Where they fail to see that intersection sometimes is how the medications that patients are taking are going to impact that cost and quality in the long run. And while we focus heavily in the Medicare Advantage space around medication adherence, there's also an opportunity to make sure that we look on the flip side to make sure we don't have medication burden that's leading to either increase in hospitalizations, adverse reactions, emergency room visits, falls. So I've had some conversations with a couple of payers who actually would like to start working around programs to help de-prescribe or help to reduce polypharmacy. And oftentimes, the approach that they want to take is just to reduce the total number of medications, which is kind of a blunt way of doing it. So we have to be more nuanced. And what I would suggest is, if you have individuals in your organization that are receiving pharmacy claims files, you have an opportunity here to start your own root cause analysis and use that data to identify your high modifiable risk members. And you can think about some basic cut points: 10 or more medications, a history of falls, age 65 and older, and a history of dementia. That is, as Maverick says in Top Gun, a target-rich environment. There is a lot you can do with just that cohort of individuals to make sure they're on the most safe and effective medications. And it's going to be a win-win for your health system and for your payer partners.
So we have a lot of questions now. Great. Let's go to the mic on this side first.
Thank you very much for this great talk. So I'm Don Scott from the University of Georgia Institute of Gerontology. I am a geriatrician. I'm not sure how many there are in Georgia, but probably not more than 100. So anyway, I wear many hats, and one of the things that I do is I'm the course director of the ECHO program for dementia in the state of Georgia. And when it comes to the topic of this summit, the risk reduction, one of the things that I struggle with is what to tell providers in terms of when we're doing provider education. And I talk to providers both in the ECHO space, and we go out into rural communities and talk to providers as well. And when I talk to them about the risks or dementia and risk reduction, they say, well, what am I supposed to do? Because, I'm already taking care of blood pressure, I'm already taking care of diabetes. Yes, I know I'm supposed to get people to lose weight and so on and so forth. So I just wanted to ask your advice and your opinion about this. What is our message when it comes to educating providers about what not they're supposed to know, but what they're supposed to do in relation to dementia risk reduction?
Thanks for the question. I feel really strongly about something that Dr. Ayala said before. As doctors, as nurses, as clinical pharmacists, our role is to say to the patient, this is important. I care about this. You should care about this. And in my role, in my work on our hypertension program, I'm working with overburdened primary care doctors all the time, and they worry a lot about how much time is it going to take in a 15-minute visit for me to have the impact you want. And to be honest, it can take 30 seconds. This is important. I want to ask about your blood pressure all the time. We're going to follow this up all the time. I want to be consistent. But it's not a complicated message, but you have a platform of expertise, and you need to convey that, using your expertise, that this is important.
Just adding to that, connecting the dots for the provider so that they understand the work that they already are doing on blood pressure and diabetes and diet is positively impacting their ability to reduce the risk factors for dementia. Making that connection clear is important. And then, as we are discussing, building into the health systems or systems in general, policies, procedures, approaches, an environment that lifts up the importance of it and helps determine what are ways that we can better engage at the community level to really have a positive impact, whether it be the meds control, but just that we've heard about getting into the house, getting out of the clinical setting and out into the community to help reinforce the importance of the ability to reduce the risk factors for dementia are just key components there.
Let's go to that side.
Bold Center on early detection. So I have a very abstract kind of question or comment. I'm good at that, and I apologize in advance for it. It has to do, as I've been listening to all of this and in the work that I do in working with health systems to try to get things to change, what's often neglected is the fact that when dementia is present, the clinician has a different set of responsibilities than when dementia is not present. In the same way that family members have different responsibilities when someone they love develops dementia, they become a caregiver. The role of the doctor changes. And a lot of what we're talking about is technological fixes and dispersion of responsibility, the sharing of responsibility from clinician to team-based care to lots of different ways of getting a job done. But in the end, it comes down to the fact that people with dementia generally cannot accept full responsibility for their own self-management. And that puts a different spin on what the job of medicine is. So I told you this was going to be an abstract kind of comment for which there's probably no real response, at least not on the spur of the moment. But I'd like to hear a spur of the moment response. And I'll tell you why.
Next question.
I'll tell you why. The reason is that the most common thing that I hear from clinicians is, how am I supposed to do this when I only have, you name it, 7 minutes, 10 minutes, whatever it is. And as soon as you start to dig deep into this, why are you limited to 10 minutes? Then you really get into a mess. So I said, you probably wouldn't have a response. You did. You said next question. But I'd like to give you one opportunity, each of you, to interact with this idea, if you would.
What I was hearing what I'm thinking as you're saying that question is the efforts are being focused to one individual in the care team, whereas the care team needs to be broadened. And as you think about the needs of a dementia patient, once they have that diagnosis and they start to begin that journey with dementia, where is the opportunity for them to be meeting with palliative care, for example? How do we bring that into the conversation earlier so that some of the things that we might have historically been doing in medicine, because that's what the measures say we have to be doing, we now begin to transition to what's going to matter most for the individual and their family as the illness progresses. So my off-the-cuff answer to you was, where's palliative care in that conversation to help offload and to not offload, but to support the needs of the individual and the family?
I don't mind the question at all. I think about this kind of stuff all the time. And it's one of the things I love about being a primary care doctor, because in a perfect world, I've known this patient even for some time before they lose some of their capacity to express their desires. Because one theme that's come up so much today has been the need for individuals to all, I wrote it down, be an equitable partner in decision making. And I understand that logistically it gets more complicated for them to be an equitable partner, but if you have any sort of background on what their wishes are and what their way of being in the world is, then you want to honor that as much as you can when the doctor relationship takes a slightly more paternalistic turn. And I think I was actually wondering if I made it clear enough in my talk how important I think it is to give the patient agency and give them the ability to understand and manage and change their own conditions as much as possible. And I would try to find a caregiver or someone for this patient who could also be able to share the patient's voice. Because I don't like when it feels, when it's very one-sided. I understand that behind your question is that sometimes it is one-sided. And we hope in the best scenario that we have an idea of what this patient would want before we are just giving them medications.
That's a great response, Jim. Okay, no, yeah, that was great, and it's a type of response that comes from that experience of directly providing care every day and understanding it. So, appreciate the question. There could be a whole summit on that question itself. Let's go to this side.
First, fantastic presentations to the whole panel. So thank you for bringing us such great practical information. And Dr. Jeffries, as far as the home visits are so critical. I mean, to really understand what's happening, where the medications are. I would just add two things that I've learned. Always check the freezer and the bingo bag, because those are additional sources of where pills will be stashed, is what I learned. And I do have one question regarding certainly what you presented about the benzos and the atypical antipsychotics. Absolutely true. But we do find in dementia, as it progresses, when it becomes a bit of an art of care, some need to have management of behavioral symptoms, hallucinations, and such. Could you give us some advice or tips of how caregivers can have those conversations with providers, in which case some of these medications might come back into a possible use, at least small doses or short-term doses?
How much time do we have? Is that going to be the next summit? You're right on this. So there's risk and benefit. It always has to be weighed when we're deciding which medications we're going to be using and at what time. In the role where I'm trying to suggest that there's an opportunity to get rid of potentially noxious medications that could be contributing to somebody's cognitive decline, then that's the group of medications that are largely identified on the Beers criteria that we want to make sure that they're not using. When it comes to behavioral and psychiatric symptoms of dementia, and you're trying to manage that, and we're trying to help with reducing caregiver burden, we're trying to keep somebody at home, trying to keep them safe, then it really does come down to fine-tuning which medication is the most appropriate for what symptom. And that's where there's a nuance to the care that I think those who do it on a daily basis are very thoughtful and are very selective and understand the role of dose. It's not one size fits all. You want to make sure that you're using the smallest, most effective dose. The saying in geriatrics is we start low, we go slow, and we sometimes say no, right? So if you're going to be picking a medication, you're doing so with a very specific target symptom in mind, with an idea of what that reaction and result should look like, so that if you don't get that result, don't continue that medication, right? So it's a bit of trial and error. And to the extent that we have to pull back in some of the medications that might be on the Beers list, it's ideally for a limited period of time in the lowest possible dose in as safe an environment as possible. And there's a lot of caveats to that statement. But I also realize there's a lot of med use that happens that doesn't have any of those guardrails with it. And we want to try to prevent that from happening in our community patients. I think to your earlier question, there's a role for payers to be able to highlight some of that prescribing by putting in, prior authorization limits, utilization management tools to help with both how much of a dose you can give and for how long you can give these high-risk medications. All of that becomes an aid to try to reduce the exposure to things that we know have potentially bad outcomes in that population.
Let's go to the side.
Hi there, I'm Marcia Ori from Texas A&M again. It's been a terrific summit, and I have sort of a bookend, and I don't know if it's a comment, a question, or a plea, but I want to go back to the importance of having both clinical to community and then direct to community, and the absolute value that I've heard about community health workers. We have 2 community health worker training centers. We also use community health workers in our 1115 Medicaid waiver. That's the good news. But the challenging news is after the grant ends, often what we find are the community health workers are the first to go. They're not sort of embedded into institutions that will pay for them. So I'd like to know if this is your experience, and or how can we get what we know is best practice to be in practice and to be financed? So I think first my question to our speaker, Nicole, and then anyone else.
Excellent question. Yes, it's definitely been a challenge to help all of the elements of the health system understand and pay for the value that community health workers bring. The journey to continue to advocate for that and educate about that is one that I was honored to be a part of in Rhode Island, and really consisted of continuing to lift up the importance of that role as a profession overall. And it's why we created here's a helpful distinction for being able to describe how they can complement each other and not overstep each other, or have the licensed health professionals say, you're doing my job. There's value and need for both of them if you want to be able to have the type of impact. And then be able to show data that demonstrates that value. And what I showed with the decrease in outcomes and the decrease in cost, improvements in outcomes, again, lifted up the benefit of both roles contributing. A licensed health professional went to the home, saw what was happening with, the bags of medication, and educated them. Then a community health worker would come to the home and it's cold in here. Is your heat on? Is that why you just can't focus and look at the meds because you're concerned about not having, your electricity or warmth, or there's nothing in your refrigerator? Are you hungry? Do you have transportation? Do you feel safe in this area? And help address all of those other elements. So the process of helping to lift that up, supported by data, helping to ensure that the organization themselves, the professionals themselves see themselves as a profession, is necessary. We supported our Community Health Worker Association of Rhode Island and made that active and embraced all of those who could be a part of that and see themselves in that profession, and connected it to Rhode Island College that helped provide support for certifying community health workers and providing a quality that's lifted up in the role that they bring, and then engaged champion health systems who understood that and saw the value, so that within the last year now, we've had legislation and Medicaid approve the reimbursement so that it can better be built into the health system approach. So it's a stepwise pattern of continuing to shape the narrative and the language and build the policy and advocacy around that group of professionals are key steps.
Yeah, I would just add to that. I think, several years ago, I think we were very hopeful that we would take a leap with respect to community health workers, because it seems like the evidence base was there. But I think in many instances, we've had to get comfortable with incrementalism in terms of establishing community health workers as a sustainable workforce. I think I'll amplify what you said. I think in addition to the community health workers being potentially the first to go when the grant runs out, our entire model of funding community health workers is not a sustainable model, where we have categorically funded community health workers, where you have a community health worker focused on diabetes and a community health worker focused on immunization outreach. I wouldn't want to see an outcome of this conference. We have the Alzheimer's community health worker. That's not the way to go, right? We need an integrated and comprehensive model of community health workers. In Connecticut, for example, I think there's some incrementalism there, and I like the idea that Nicole raised about broadening the concept of what a community health worker, what they call themselves and what their job titles are. We've recently, for our Medicaid program, recently reimbursing for violence prevention professionals. So these are folks that work with people who are victims of gun violence, and they're community based, and they can reimburse for the services. I believe doulas are also on deck for reimbursement in our state. So there is this incrementalism happening, and we're hopeful down the road that there'll be a broader strategy for covering those services.
So if I can just jump in on that for those who are looking for another grant idea, take the language, the skills, the training that a community health worker gets, pull out the relevant pieces that you might want to impart to the pharmacy delivery driver who's going to the person's house once a week to deliver their medications, who's already getting access to that environment and can be that reporter to tell you what's happening there. I think there's an opportunity to partner with individuals that are already providing trusted services in the community that could help to bring that information back. So I don't know if the Alzheimer's Association is listening, but if you'd like to fund me on that, I'd be happy to take that project and run with it.
All right, we have time for one more question.
Hi, everyone. Thank you for letting me have the last question. My name is Lauren Hale, and I'll be speaking tomorrow about sleep health. And that's something I'd love to hear from all you about the role that you see in care of addressing sleep health in the population. Treating sleep is a vital sign. Every doctor's visit takes blood pressure, but they don't ask about sleep health. What community health workers, you already pointed out some things like temperature and food insecurity. Those things matter for sleep health, and what's being done to address sleep health. And for Dr. Jeffrey, I'd love to hear, what's the balance? We know improving sleep health is good for cognition, but that list of drugs that people should not be taking are often drugs to help with insomnia. And so what's the trade-off there? So any comments on sleep? This will help me answer some questions that may come to me tomorrow. So please.
First, I think sleep health is a snoozer, but it's the end of the day. So my take on sleep medications is that it's always a proxy for something else that's going wrong. And I teach my pharmacy students there's really no safe sleep medication. And I'm challenged to find the true patient that may benefit from the medication, that it's just an insomnia. It's nothing else. It's just problems with delayed sleep or sleep latency or sleep onset, right? So there's usually something else that's driving the challenges with sleeping. And because I'm a hammer and everything I see is a nail, it's always a medication there that is causing that problem in my world. So I look at the medication regimen, thank you, and I try to find what meds might be causing that person to not get a good night's sleep, because we're now giving them a med to help them sleep. And we're now on this yo-yo cycle of something that's making you drowsy, and then we're trying to perk you up later with something else. I'll leave you with a little fun saying here, Tylenol PM, right? It's a sleep aid, right? Do you know what the PM stands for? Post-mortem. We don't want to be using it in our older patients because it causes them to fall. It causes them to have cognitive impairment. That Benadryl, even though it seems like it's a benign agent that you might use for sleep, has potential downstream harm in a person who has cognitive impairment. So think about it as post-mortem. You'll never be using it again in older adults.
I appreciate that question too. We do talk about sleep definitely in provider training when it's sort of second line difficult to manage hypertension. But one thing that I've been reflecting on as a result of the summit today is just how overlapping so many of our successful strategies are, right? Somebody was mentioning a study that gosh, when we have patients eat more fruits and vegetables and they move more, surprise, surprise, their emotional health is a little bit better. And turns out they sleep better too. So, and these are things that reduce the risk of dementia, but they actually improve life in a much shorter term as well. So patients often want a quicker fix than that, but I think the messaging is consistent and in their best interest.
I'll quickly add that builds on what Dr. Jeffrey shared with the community lens and that broader public health perspective. The stressors that are occurring in certain communities, places that have been disinvested in, would absolutely contribute to an individual's inability to rest peacefully at night. So being able to really focus attention and resources and strategy into the living conditions that someone is impacted by, or paying attention to the allostatic load that can occur cumulatively when someone is exposed to racism and other isms that impact the stress of individuals over time, would ultimately positively impact their ability to rest and have emotional wellness and peace of mind with their economic and environmental surroundings.
All right, with that, let's give them a round of applause.
I want to quickly just add my thanks to this panel. You all did an amazing job. I mean, it was really fantastic. I was struck all day, community clinical linkages kept on coming up and up and up, and, the bar kept on getting raised. But all three panels really did outstanding, and Rahul and your colleagues really hit the ball out of the park, as they say. So really good. So we're gonna, So just again, thanks. I thought what Jewel and I sort of were convening we've got a couple of themes from today that we'd like for you to take home and think about them overnight, and then sort of we'll continue on tomorrow. So here are some of my sort of thoughts. One was shining the light on the issue and sort of being able to be really pithy in terms of what you say and sort of being able to lift that up so your leadership can do that. Janet Wright brought that up. She brought up having each of your coalition members and others bring their own metrics as part of the work that they do. I thought all the work around coalitions and partnering and sharing of power and really ceding power to community groups is really important as we think about this work. Partnering with not individual groups, but partnering with networks was another theme that I heard. Start with the end in mind, I thought was really important too. Thank you for that, Marcia. That was really good. Use of data, but really the power with data is the stories that are behind that, and sort of being able to lift up some of those stories is really important. Partnering with community pharmacists, I heard sort of at the end today. And then the last thing, which I think is going to be my theme, and this is something Dan said at the end, let's make it happen. And I think that's the power today. Jewel?
So we sat next to one another, and I didn't cheat. There's nothing on my list that was on Wayne's list. Thank you all, including thanks to everyone for your questions. As a primary care doctor, I have to say, I sat at the end thinking that we went all the way from what Dr. Omura also reminded us, from primary all the way over to tertiary prevention. And there was something about your question, Dr. Jerry Trishman from Georgia, I don't remember your name, who that also reminded me how deeply we care about this, because so many people get to a point where they don't know what they can do. And so coming all the way back to the very beginning of where we started, and remembering that there are things that we can do. And I know this probably doesn't really make sense from a public health standpoint, but I said to Lisa McGuire, maybe one of my messages will be that risk reduction is the cure. And I know that's not quite right, but I also wanted to bring us back to where we started and to keep us thinking about all of the assets that we talked about today, including some of the other points which I heard, which included that it's never too late to promote brain health. Their mission is your mission. You have to start somewhere. Never be afraid to start. Caregivers are a point of prevention. Older adults expect quality service. And quality is the other word I use every time I talk about equity, because the Q word is easier for people than the E word. But we're talking about quality public health, quality healthcare. Data aren't good until you have a good process in place. Trust the process of becoming trustworthy. Don't let the perfect be the enemy of the good. And hitch your wagon to someone else's wagon as you prepare to come back tomorrow when we start at 8:30. And please, please, keep your badge and bring it back with you tomorrow. It will speed up the process of your getting in. I hope you're both tired and really energized. And one other thing I have to say, Wayne and I are the co-chairs who did so much work to try to keep up with Matthew Baumgart,
Yes.
who works so much hard. So I look forward to another fantastic day tomorrow. Thanks, everyone.
Thank you.